If you were to design the perfect value-based contract, what would it look like?
I'll be happy.
Yes.
First of all, it would be way less complicated. I have so many people who are in actuary, finance, contracting, what have you, trying to figure out what our baselines are, what our targets are, how did we do. It's way too complicated. And then secondly, it's, you know, we talked about kind of the provider incentives. We might get paid 18 months, 2 years later from the performance period. Our doctors are happy when they receive a check, but they're like, I don't know what I did 18 months ago. We need more real-time measurement, real-time potentially payment. It's too long of a cycle between contracting and outcomes measurement.
Great. Andy, you look like you want to say something.
Yeah, so I've spent most of my career on the payer side, but I did do several years representing risk-bearing entities in my private equity days. So I think one of the most important things payers need to do, and they don't always do it, is actually be wildly transparent on historic MLR, RAF, STAR quality scores, be wildly transparent on benefit changes, bids, filed MLRs, be a good payer partner. Just because, you know, there is information asymmetry on the payer side of the equation, but if you really want to like set providers up for long-term success, you can't use that to lob a risk grenade over the wall and say good luck. And I remember earlier in my career, it was like, oh, we just offloaded a bunch of underwriting loss to this risk-bearing entity, and then now you either have to collect a 7-figure check from them or forgive them or carry the deficit forward. And like, that is not the right way to do risk from a payer's perspective. Set providers up for long-term success.
Arkos. I have to jump in here too. So thank you. Yes, 100% agree. For us, as a provider organization, I think multi-payer, my ideal contract would be across payers, so multi-payer, a narrowed set of clinical quality measures that make sense and are, that we know improve patients' outcomes, that has stable attribution and understandable attribution so that patients don't shift between models, even within the same organization, and benchmarking that is transparent, understandable, and real, and that we minimize risk adjustment as much as possible, or minimize current risk adjustment, or expand risk adjustment to really capture what we know is the true risk of patients that leads to poor outcomes.
And multi-year, probably.
Yeah. Thank you. Absolutely.
Eric.
Yeah, no, I mean, I agree with everything that was just said. I think we should be paid for what we do, and I think a lot of the times in the value-based contracts, there's quite a bit in there that the provider or on the other end of the, you know, whoever's on the other end of the deal doesn't necessarily control, but yet they in their either naivete, and that was us a little bit, or in their, you know, optimism, say, yeah, of course I can, you know, take Part D risk with no understanding that GLP-1s are about to blow up the entire, you know, industry there. So I think ultimately what was talked about earlier, wild collaboration, right, between the payer and the provider or the enablement company or whoever. If you get to that, you're going to get to a better result.